Are we live? Okay. So, good evening, everyone. Welcome to our monthly talk on from Optima, where we discuss some common topics for general public. And today we have a very interesting topic and a very interesting speaker with us. So we have Dr. Mitesh with us. Dr. Mitesh is a senior interventional cardiologist who specializes in complex coronary interventions, including image-guided precision angioplasty and chronic total occlusion angioplasty. He's also pursued advanced training in structural heart disease and has performed hundreds of such procedures. So we are very excited to talk to our guest today, Dr. Mitesh. Welcome, Dr. Mitesh.
Thank you, Dr. Vikram. Thanks for having me.
Yeah. So, Dr. Mitesh, I just want to start off with something which happened recently in our hospital. So, our receptionist, she's only 35 years old, and she was absent for a few days. And then later on, I got to know that she had a heart attack. So it was very interesting that we always associated heart attack usually occurs in men with other risk factors. And I was really surprised to know that she had a heart attack. So how is this, Dr. Mitesh? Can you just explain what could be the reason for a heart attack in a young lady?
So, Dr. Vikram, see, traditionally heart attacks we see are in men, and in women we often see that they get heart attacks post-menopausal state. After they cross menopause in the late 50s, 60s, 70s, we see heart attacks. Heart attack is relatively uncommon in young women. Having said that, there are certain conditions which can lead to heart attack in young and middle-aged women. And one of the conditions being spontaneous coronary artery dissection, what we call as SCAD. This is a relatively less known condition and often misdiagnosed, but very important to understand and know. And there needs to be increased awareness about this condition.
Okay. So how is this different from a traditional heart attack, this CAD, which you mentioned?
So you see a traditional heart attack happens because you gradually develop a fatty plaque deposit in your artery wall, artery supplying blood to the heart, which gradually over many years starts building up, eventually leading to a heart attack. But what happens in SCAD? SCAD happens in patients who have absolutely normal coronary arteries. When I say a coronary artery, it is an artery supplying blood to the heart muscle. And an absolutely normal artery all of a sudden develops either a bleeding in the vessel wall or a tear in the vessel wall, leading to a sudden narrowing of the lumen or the passage through which the blood flows and causes a heart attack. This is what happens in SCAD.
Okay, so this is interesting. So this young lady probably she didn't have any other problem. So probably she must have had SCAD, is what I understand. But are there any risk factors for SCAD? And you said that it can affect women also. Why does it seem to affect women more, especially younger?
So see, a conventional heart attack, which happens due to a fatty plaque buildup, we know it happens because you have underlying conditions like hypertension, diabetes, high cholesterol, smoking, a strong family history. Okay. These are the risk factors for a conventional heart attack. But unfortunately, we don't understand what are the risk factors for SCAD. Having said that, there is a lot of data which says more than 90% of times these episodes occur in women, suggesting possibly there is an underlying hormonal predisposition. In young and middle-aged women, there is an underlying hormonal predisposition. Also, sometimes heart attack, though very rare, but if at all they happen in pregnancy, SCAD is a very high possibility. Also, sometimes young women, when they're on treatment for infertility, they can develop SCAD. All these point towards an underlying hormonal predisposition. And sometimes you have certain triggers like extremes of emotional stress or extremes of physical stress, again, which can lead to an acute episode of SCAD in susceptible individuals.
So this sudden coronary artery disease, right, that is SCAD. So
SCAD is basically spontaneous coronary artery dissection.
Spontaneous coronary artery dissection. So spontaneous coronary artery dissection, what would be the key symptoms? Like how can one think of SCAD? How would it be different from other heart disease symptoms?
So as I told you, SCAD, if whatever the reason for heart attack could be, either SCAD or a conventional fatty plaque buildup, the symptoms are going to be the same. Symptoms are those of a heart attack. Like you would have sudden onset chest pain, you have sweating, you might feel nauseous, you might have vomiting, you might feel lightheaded, palpitations, those typical symptoms of an heart attack. So based on symptoms, you cannot suspect who has SCAD or who has a traditional heart attack.
Okay. Okay. So, so then how is CAD diagnosed, and what makes you to suspect SCAD in your patient?
So the most important element to diagnose SCAD is suspicion.
Mm-hmm.
Like you told me that there was a 30-year-old lady. If
Mm-hmm.
I have a 30 or 40-year-old lady who does not smoke, who does not have other conventional risk factors like diabetes, high blood pressure,
Mm-hmm.
high cholesterol, no strong family history of heart attacks, and walking into my emergency with an heart attack, even before I take her for an angiogram, I have SCAD as the first possibility for her. Only when I have the suspicion in mind, I would look features suggestive of SCAD in the angiogram, and I will make a diagnosis. Without suspicion, just looking at an angiogram, you often miss this diagnosis. So the most important thing is suspicion in the clinician's mind that, okay, I might potentially be dealing with SCAD, and only then I would actually actively look for SCAD, features of SCAD.
Mm-hmm. So that means, from what I gather from you, there may be many patients who are missed because they're not suspected of SCAD. Does it happen?
Often, yes, often. So,
Okay.
and only once you have suspicion, the most important element to make a diagnosis is
Mm.
doing a conventional coronary angiogram and not CT coronary angiogram. So it's often missed again on CT. Even if a patient with heart attack undergoes a CT coronary angiogram who possibly has an underlying SCAD, very oftenly you'll miss. So you need to undergo a catheter coronary angiogram, what we call a conventional coronary angiogram in a catheterization laboratory. You do the angiogram, read the angiogram carefully. It will give you 80 to 90% of patients can be diagnosed only based on the angiogram. About 10 to 20% of times, you might need additional tools like intravascular imaging, an intravascular ultrasound, or an optical coherence tomography catheter, OCT. It's like a camera taking into the blood vessel and studying the vessel wall.
Interesting, Dr. Mitesh. So now you said that this dissection, which is spontaneous, which happens in the coronary vessels, that is the blood vessels, um, can this sometimes heal off on its own? Does it always require some this thing? Does it sometimes come and people may not realize that they had scared and heal off on its own?
So the beauty about SCAD is once a patient comes to me with a heart attack and we diagnose him
Hmm.
or her with SCAD,
Hmm.
a majority of patients get better only with medical therapy.
Okay.
And there is complete healing of the vessel wall and heart function in 6 to 8 weeks.
Okay.
Small number of patients due to either ongoing chest pain who do not respond to medications or who are unstable either because of low blood pressure or who have unstable electrical rhythm require some form of emergency treatment in the form of an angioplasty or even very rarely a bypass surgery. But the beauty about SCAD is if you diagnose it rightly, a majority of patients don't require any form of intervention. They improve only with medical therapy. After a couple of days of hospitalization, we discharge them. And in about 6 to 8 weeks, there's enough data that initially we used to do a repeat angiogram and see whether the tear is healed or not. And now there's enough data to say that it heals. You don't have to do a repeat angiogram. Just leave them on medications and follow them symptomatically.
That's nice to know that majority actually do well with medical management. They don't require any intervention as such.
But even to give an option of medical management, first you need to diagnose it as SCAD.
Diagnose it.
The contrary, if you presume that this could be an atherosclerotic disease, you would end up doing intervention.
Mm-hmm. Now, Dr. Mitesh, yeah, you said this affects young to middle age, and you also talked about hormonal influence. Do we really understand what is the role of pregnancy or this hormones or stress? How does it trigger SCAD? Do we really understand what happens there?
So what happens is, so we really don't know exactly what happens, but what we believe is that these hormones induce some kind of changes in the vessel wall.
Mm-hmm.
They change the composition of the smooth muscles, other arterial matrix, such
Mm-hmm.
that these vessels are become more fragile and are more prone to tears and dissections,
Mm-hmm.
hence develop SCAD.
Okay. Now, when somebody has a heart attack, most patients will advise, okay, change your lifestyle, control your diabetes, control your hypertension, control your cholesterol, exercise, and all that stuff, along with medical and whatever interventions you do. But scared, there is no definite predisposing or no risk factors as such. So,
Uh-huh.
still, do we advise any lifestyle modifications, diet and exercise in patients who have scared?
Yeah. So see, for diet, regarding diet, I would say there are no recommendations for diet because, as I told you, this is not because of a fatty plaque buildup. It
Mm-hmm.
is just because of current tear. But
Okay.
other than that, definitely for the first 6 to 8 weeks, we tell them avoid any kind of exertion, just
Mm-hmm.
basic activities, no exercise, no heavy exertion to allow time for the vessel to heal. Once the healing process is complete, after that, you have certain recommendations that they should be going through a supervised cardiac rehabilitation program. And there are certain exercise recommendations, what is allowed, what is not allowed, what is the limit that they can lift weights or do weightlifting exercises, beyond which possibly it might not be very safe, or beyond which if they lift, it might again trigger an episode of SCAD. And
Think we have lost Dr. Mitesh on the network here. There's some network issue. So far we're discussing about this condition called as SCAD, that is spontaneous coronary artery dissection, and how it usually affects young to middle-aged women. Dr. Mitesh,
the
I
mental
think
health issues needs to be addressed.
okay. Dr. Mitesh, I think we are not. I think there's a network issue. Yeah, Dr. Mitesh will be rejoining. So far we discussed with Dr. Mitesh, senior intervention cardiologist, about a condition called as CAD, it is spontaneous coronary artery dissection, where we discuss how it usually affects young to middle-aged women, with majority of patients, and they usually don't have the traditional risk factors for heart disease. Yeah, we've got Dr. Mitesh back. We were discussing, Dr. Mitesh, I think there was a network issue about the lifestyle modifications and when normal activities can be bought out in patients with SCAD. Please continue.
So as I already told you, so there are no specific dietary recommendations
Mm-hmm.
regarding lifestyle. I think you can lead an almost normal lifestyle with certain restrictions with regard to what kind of physical activities are allowed and not, how much
Mm-hmm.
weight can you lift are there after about 6 to 8 weeks. So for the first 6 to 8 weeks, you need to allow time for the vessel wall to heal and the SCAD to resolve.
Okay. I think there's a network issue again. So just to recapitulate what was we discussed about the SCAD, and usually there are no traditional risk factors. Normal, so ಸ್ಕ್ಯಾಡ್ ಅಂತ ಒಂದು ತೊಂದರೆ ಬಗ್ಗೆ ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಡಾಕ್ಟರ್ ಮಿತೇಶ್ ಹತ್ರ. ಸೊ ಈ ಕಾಯಿಲೆಯಲ್ಲಿ ಈ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗತ್ತೆ ಯಂಗ್ ಮತ್ತು ಮಿಡ್ಲ್ ಏಜ್ ಮಹಿಳೆಯರಲ್ಲಿ. ಸೊ ಬೇರೆ ಟ್ರೆಡಿಷನಲ್ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಇಲ್ಲದೆ ಇದ್ರು, ಶುಗರ್ ಇಲ್ಲ, ಬಿ ಪಿ ಇಲ್ಲ, ಕೊಲೆಸ್ಟ್ರಾಲ್ ಇಲ್ಲ, ಸ್ಮೋಕಿಂಗ್ ಇಲ್ಲ, ಬಟ್ ಸ್ಟಿಲ್ ಕೆಲವರಿಗೆ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗ್ಬೋದು. ಸೊ ಆ ಕಂಡೀಷನ್ ನ ಸ್ಕ್ಯಾಡ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ ಇದನ್ನ ಡಯಾಗ್ನೋಸ್ ಮಾಡಕ್ಕೆ ಯೂಶಲಿ ಸಸ್ಪಿಷನ್ ತುಂಬಾ ಡಾಕ್ಟರ್ಗೆ ಅದ್ರ ಬಗ್ಗೆ ಯಂಗ್ ಪೇಷಂಟ್ ಅಲ್ಲಿ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆದಾಗ ಅದನ್ನ ಯೋಚನೆ ಮಾಡ್ತಾರೆ, ಅವಾಗ ಅದನ್ನ ಕನ್ಫರ್ಮ್ ಮಾಡ್ತಾರೆ ಎಂಜಿಯೋಗ್ರಾಮ್ ಮಾಡಿ. ಸೊ ಡಾಕ್ಟರ್ ಮಿತೇಶ್ ಇಸ್ ಬ್ಯಾಕ್. Yes, Dr. Mitesh, I think there is some network issue. So uh, we were discussing about exercise, and you said how they can come back to normal activity. You also mentioned that uh, can SCAD come again? Like somebody has a SCAD, can they experience further episodes of SCAD?
Yeah, that's a very relevant question. So patients with SCAD have a small risk of recurrence.
Mm-hmm.
So there's a risk of recurrence of 1% every year, 1% per year, or you say about 10% over the next 10 years. So in the
Hmm.
next 10 years, there's a 10% probability you might experience another episode of SCAD.
Okay, okay, that's interesting. So yes, you also told about yeah. Now, when as a rheumatologist, I also when we see patients, young women who develop come with heart attack, we think of conditions like antiphospholipid syndrome, etc., where they can have uh, cardiac issues as well. Now, this is something which is new, and this is something which even I was not very aware of this. So I'm sure there is not too much awareness of this condition. So have you come across, do you come across, or your colleagues come across frequently patients with SCAD? Yeah, so I think again there's a network issue. So Dr. Mitesh will be joining us. We were discussing about this SCAD, where it is usually suspicion is required. The doctor has to think about in a young patient when it comes with heart attack without any traditional risk factors. Angiogram usually shows SCAD, and then usually it is some hormonal changes which causes this sort of problem during pregnancy or during uh, in IVF, etc. Uh,
Sorry, my apologies, Dr. Vikram. There's some unstable internet.
Okay, no problem. Can we use a different? Yeah, yes. Can you hear me now?
Yeah, I can hear you now.
Yeah, yeah, perfect. So we were just discussing that usually as a rheumatologist, I think of when I think of heart attack in a young woman, we think of uh, antiphospholipid syndrome. That is still rare, antiphospholipid syndrome. Uh, I understand that SCAD. Even I was not aware of this condition till I was discussing with you. So how common is it, and do you frequently see this in your day-to-day practice?
Yeah, we do. I mean, I see. It is like this. A majority of leave your phone here on silent. क्या नाम है? Am I audible, Dr. Vikram?
Yeah, audible, yes.
1+60. Am I audible now, Dr. Vikram?
Yeah, yeah.
So I'll give you an interesting case. I recently had a 29-year-old lady who's on treatment for infertility, and she comes to me with a heart attack. Very difficult to diagnose. It needs to start with telling a 29-year-old lady that I need to do an angiogram, and she's like, "Doctor, are you serious?" So luckily, she was relative of one of our staff in the hospital, and it was relatively easier to convince her. We did an angiogram. We had certain features where we suspected SCAD, but something, it was not a very typical SCAD. So we told her, let us do an angiogram, repeat angiogram after 6 weeks. She did come after 2 months, and we repeated her angiogram, and the vessel wall healed beautifully, no blockage, nothing, confirming after 2 months that this was SCAD. So now this lady has implications because now she's on treatment for infertility. Diagnosing SCAD for her has implications. She's at a risk of developing again during pregnancy, as I mentioned, due to hormonal changes during pregnancy and in the next couple of years. So for us, having a baseline diagnosis of SCAD in her is very, very essential. If she develops a repeat episode of SCAD during pregnancy, we know what to do, how to treat her. If an angioplasty needs to be done, there are specialized techniques. They behave differently than how a patient would a conventional heart attack behave due to an angioplasty. So that it is very important to understand what you're dealing with.
You interestingly you talked about this. So are patients with SCAD can they still undergo their IVF? Can still they undergo pregnancy, or is that something which we would ask them to avoid?
Yeah, so it's a double. It's a very difficult question to answer. We do not have any recommendations regarding that, but we know they increase their susceptibility. So how long should they wait before they conceive? When can they safely conceive again? And what are the chances during pregnancy to repeat experience another episode of SCAD. We do not, unfortunately, we do not have enough data and answers to these questions.
Okay, Dr. Mitesh. So can a patient with SCAD, now you're diagnosed with SCAD, do they have or should they do some precautions? Can they do some precautions to say to avoid a further recurrence of SCAD? Or is it something which is not in our hands?
So as I told, I mean, the only precautions, if you already had a SCAD, let's say you already had a SCAD. So there are two scenarios. One, patient has already had a SCAD, and to prevent a recurrence, as I told you, avoid extremes of emotional or physical stress. So if you're already dealing with some mental health issues, you need to consult a psychiatrist, needs to get those sorted out. Otherwise, again, at extremes of emotions, it can trigger an episode of SCAD. If you're physically very active, there are certain recommendations. Okay, typically we say avoid very high intensity sports, avoid your aerobic activities are allowed, avoid weightlifting beyond a certain limit. Like for women, typically we have about 10 to 15 kgs. For men, about 20 to 25 kgs, beyond which is not permissible or it is considered relatively unsafe. So these are the recommendations. Avoid any recurrent episode. Other than that, as I told you, we still do not completely understand why certain individuals develop this and why certain individuals don't. We do not have enough data.
Yeah. So patients with SCAD are usually on medical management, most of them. So how long would you usually continue their medical management? Do they have to take it for how patients are
So,
like traditional?
so the current expert recommendations are that we usually continue medications for 2 years and then we take them off medications. And another important, very important question, I'll tell you, this is one of the most relevant questions. When I have a patient with a conventional heart attack, I have medications like statins. I have medications like ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonist, all those medications which very, very essential in treating a post-MI patients due to a conventional heart attack, but they have absolutely no role in a patient with SCAD because a patient with SCAD do not have a diseased intima. The vessel wall is normal. So statins absolutely have no role, whereas statins are one of the most important pillars of treatment in a conventional heart attack. So as I told, that's why I tell you that it's very important to have a very clear distinction as to what are you dealing with. Only then you know what are the secondary prevention measures, what is the prognosis, what is the recurrence risk, and how to treat them in the future.
Okay. Interesting, Dr. Mitesh. I think for our viewers, I just want to explain statins are medicines to reduce cholesterol. So what we use, if somebody knows the patients with heart attack, they will be on aspirin, they will be on cholesterol lowering medication, they'll be on medications um, like ACE inhibitors. So these are medicines which you usually in blood pressure as well as in heart disease. So these medicines, traditional medicines, are usually not probably used in patients with SCAD. Dr. Mitesh, uh, yeah, you answered about the how the symptoms can be very similar. They are exactly similar to heart disease, how it is suspected and how we manage. Are there any recent advancements in treatment of SCAD that patients should be aware of?
So treatment-wise, as I already told you, antiplatelets and beta blockers are the cornerstone of therapy for SCAD. But more importantly, nowadays, we have some data which says a lot of studies are going on in patients with SCAD. About 50% of patients who have SCAD, they have an underlying condition called fibromuscular dysplasia. Again, as I told you, it's a generalized arteriopathy where the vessel wall is weak, prone, making the vessels in different parts of the body prone to aneurysms and dissections. And studies have confirmed about 50% of patients with SCAD have an underlying FMD. So every patient with SCAD we diagnose, we put them through FMD screening where we do a whole body CT angiogram and look at vessels in different territories.
Dr. Mitesh, again, we have lost him to network issue there. So we'll be next taking up our question answer sessions.
Am I there, Dr. Vikram?
Yeah, Dr. Mitesh. Yes.
Yeah.
Can you?
So I was telling 50% of patients with SCAD have an underlying condition called fibromuscular dysplasia. So every person who's diagnosed with SCAD, we put them through a whole body CT angiography, wherein they undergo CT angiography head to toe, right from the cerebral circulation till the mid-thigh, and we'll look for evidence of FMD. And that again has future prognostic implications for these patients. And there are a lot of genetic studies.
Thank you, Dr. Mitesh. I think we just...
as of now, we do not have any recommendation.
Okay. Great. Dr. Mitesh, I think we'll just take up a few question answers from the audience. Yeah. So Ranjita is asking, can heavy lifting in workout cause CAD? Like patients in...
Yes. So as I told you,
please go ahead. We can hear you.
As I told you, so as I told you, extremes of physical stress, right? Sometimes we hear that people were doing heavy workout in the gym and they have an heart attack. So SCAD is a potential consideration in this setting, that if you're doing very extremes of workout, especially you're unaccustomed to it, and one fine day you decide to hit the gym and start doing very heavy workout, yes, you can develop SCAD because of extremes of physical exertion.
Okay. One more question is, can SCAD occur, if you said it occurs in the artery, can it occur in the same artery every time, or it's like can affect a different artery? That's a question from one of the viewers.
I have seen patients with SCAD coming 4 times. The maximum I've seen a person coming with is 4 times. And this SCAD can affect the same artery. It can affect different arteries.
Okay.
So I have seen somebody coming with SCAD involving all 3 different arteries. Sometimes patients can develop SCAD simultaneously in more than one artery.
Okay.
So patient has had SCAD in 2 of the 3 arteries. Often it is a single vessel which is involved. Sometimes we've seen double vessel SCAD. Same time patient has SCAD involving 2 arteries. And sometimes a patient, let's say, now comes to you with a SCAD involving right coronary artery. After 3 years, he comes with a SCAD involving the left circumflex. After 6 years, comes with a SCAD involving left anterior descending.
Okay. So, Dr. Mitesh, a very simple question which it's just struck my mind. So, it can affect young women, middle-aged women. Is it life-threatening in some patients or most patients? Can it be life-threatening?
Yes. So yes, it can be life-threatening, right? So let's say it all depends on how serious the SCAD is going to be. It all depends on what portion of the heart is at risk of reduced blood supply. Let's say I develop a SCAD involving a very large artery in its proximal segment. So like 50% of heart is suddenly devoid of blood supply. And unless you emergently restore perfusion in this territory, you can lose these patients. Sometimes patients... I have an interesting patient, I'll tell you. We had a 30-year-old lady coming. All of a sudden at home, she just collapses. Rushed to the hospital and kept in the hospital for about 2 to 3 days. And the working diagnosis was she's having myocarditis, acute myocarditis. And suddenly, the patient is not improving. There is no reason to believe she could have myocarditis. There's no history of fever, no underlying connective tissue disorder or autoimmune conditions. And just thought of, let's do an angiogram. And she had a SCAD involving the left main coronary artery. And underwent an emergency bypass surgery, improved, recovered, went home. But then again, these are sometimes can be dangerous and life-threatening. If not diagnosed, we would have lost her.
Thank you, Dr. Mitesh. I think we had a good discussion about this condition called SCAD. Lot to learn. SCAD is a condition, obviously, which can affect young women, middle-aged women, without any risk factors, and needs to be diagnosed appropriately and managed because it can be life-threatening. Any take-home messages for our patients about this disease, Dr. Mitesh?
I mean, if I have to give one message, this would be any lady, especially who's below 50 or around 50, who has suffered a heart attack and who's wondering, I never had diabetes, I don't have blood pressure, I don't have cholesterol, I don't smoke, my parents, my siblings have been healthy, nobody's had a heart attack or heart problem in the family. I think SCAD is a potential consideration in you, and you need an evaluation for that.
Wonderful, Dr. Mitesh. Thank you. I think points well taken. All our audience, please, I'm sure would have kept this in mind. The take-home message is a young lady below 50 years without risk factors. If you had a heart attack, obviously, we should obviously discuss about this condition called a SCAD. If you have more questions, please put it in our chat. We will take it up with Dr. Mitesh and answer your queries. With this, I think we are about time. We will like to wrap up this session today. Thank you, Dr. Mitesh. Thank you for taking time and answering our questions patiently. There were some glitches. Apologize to our viewers. We'll see you next month. Thank you again, Dr. Mitesh, for your time.
Thank you, Dr. Vikram. Thanks for having me.
Thank you.
And again, my apologies.
About time, we will like to wrap up this session today. Thank you, Dr. Mitesh. Thank you for taking time and answering our questions patiently. There were some glitches. Apologize to our viewers. We'll see you next month. Thank you again, Dr. Mitesh, for your time.
Thank you, Dr. Vikram. Thanks for having me.
Thank you.
And again, my apologies.
About time, we will like to wrap up this session today. Thank you, Dr. Mitesh. Thank you for taking time and answering our questions patiently. There were some glitches. Apologize to our viewers. We'll see you next month.